Today I am talking about nurses' role in poisoning care. During my 20 minutes lecture, I will tell something about the epidemiology of poisoning in Sri Lanka, as well as systematic approach to the patient with the poisoning, and what is the nurse's role for the poisoning care. Actually, what is poison? Poison is a substance, it may be natural or synthetic, that causes damage to the living tissue. What are the types of poison that we encounter? There are only two types of poison. One is natural, other one is synthetic. What I call is God-given one and the man-made poison. God has given the plant and the other animals. We have created our own poison. Those are medicines, pesticide, sometimes this household and the industrial chemicals. Is it a common problem in Sri Lanka? Yes, there are more than 80,000 patients admitted with the poison every year. About 75% of those are intentional poison and rest accidental poisoning. This accidental poisoning more common among children. We have to be very careful about that. What are the routes that can enter this poison into our body? It may be inhalational, oral, dermal or ocular contact, or sometimes parenteral. See, there is a patient, I'll call him Mr. N. He's a 46-year-old male living with his daughter and found unconscious. Ambulance people brought this patient to your hospital. How we are going to care about this patient? Most important thing that I want to highlight, the time is life. In MI or the stroke, we say time is muscle, but in poison, remember time is life. Your delay in 2-3 minutes can cause death or lot of complications. If you act very quickly, you may be able to save the life without any complication or without death. Other important thing I want to highlight in this is the compassionate human care, which we are going to talk in details in our next lectures. This is a human being like us. You know, for any person or even any animal living in this world, they like to protect their life at any cost. They fight till their death. That's the nature of any living being. For patients who come with the poison also, it's the same. They want to live. But because that person psychologically unstable at that particular point, he can't take correct decision. That's why this patient has taken the poison. And patient is having more psychological burden. When these people come to hospital, if we add more burden to them, is that human? Is it the care that we are going to give? I know a lot of people are not behaving like that, but still we see in ward some medical staff, including doctors, nurses, minor staff, towards this poison patient as well as for the alcoholic patients, our attitude may not be that great. Then, what are the nurses' role? Actually, nurses' role start even before patient comes to the hospital. We have to be very knowledgeable and skillful to manage these patients. That's what we all are doing right now here. And other thing, the dedicated area in your hospital, in your institution should be, we have to decide which area we are going to keep the poisoning patients. Sometimes some procedures we may have to undergo for these poison patients. I think most of the medical ward has that area. And other thing, the important thing, emergency trolley should be ready. We can't find, sometimes there may not be the necessary drugs. Or laryngoscope may not be functioning, batteries may not be there. And some other essential drugs, sometimes ET tubes may not be there. We experience those things in several occasions, but it's our duty to check it daily and check whether it's working. It should be ready to use. It's very important. How we are going to approach to Mr. N. There is a standard pathway, what we call resus RSI dead pathway. It is resuscitation, risk assessment, supportive care, investigations, decontamination, enhanced elimination, the antidotes and disposition. Anyway, patient needs resuscitation. Resuscitation will be the first step, but other steps you may change the order according to the priority of the patients and the conditions of the patient. Resuscitation of a poison patient, usually when we ask from anyone, we'll ask what is the approach, ABCD approach. But it has very good or very meaning in the when we come to the poison patient. You know, airway. There is several ways that compromise airway in a poison patient. Patient may be unconscious, the tongue may be falling back. Patient may have vomited, lot of secretions will be there and it will be obstructing. Patient may have exposed to some corrosive substance. There may be swelling in the airway. You have to make sure airway is patent. The breathing also the same. You have to count the respiratory rate, and not only that, respiratory pattern, chest movements, those are very important, and check the oxygen saturation. It is very important. And the circulation, very, very important aspect. Some poisons you know can cause tachycardia, tachyarrhythmias, and hypertension. Some poisons can cause low blood pressure, bradycardia, even cardiac arrest. If it is so, you have to detect it. And other important neurological primary survey is very important. You have to detect and correct. What you are going to detect, especially hypoglycemia. Most of the poison patients will have hypoglycemia. You have to detect, and you can easily correct it. Other important thing, the E for environmental control or exposure control, there may be contaminated clothes as well as skin. You have to remove the poison from there as well. Again, there may be associated injury. Same time, during this resuscitation process, other important thing, you can do the emergency or use the emergency antidotes. Okay, other important aspects, risk assessment. You can easily do that with this WH questions. Who is this patient? What kind of poison he has taken? What is the amount? And what are the diseases this patient is having with the renal failure, with the liver failure? Those are very important for management of these patients. And when this patient was taken this poison, where? What happened up to now? What is the reason this patient to take this poison? The person who we were referring, Mr. N, he lives with his only daughter. Wife died about 4 years ago following accident. He cared about this daughter. There is no any other one to look after daughter. This daughter is doing A-level. She had some affair with the boy. He's a drug addict. He came and threatened this person, and he was upset. Found unconscious. We don't know what has happened, whether this is a suicidal act or homicidal act. Okay, now this patient came to hospital. What you are going to do? You have to decide where this patient you are going to keep. You can't keep this patient in the corner cubicle. By the time you attend, patient will be die. And because of that, it should be somewhere near to the nurse's station where we can easily monitor the patient. And other thing, once we go, we have to position the patient correctly, left lateral or recovery position. And if patient saturation is low, you may have to give the oxygen. You have to insert wide bore cannula, at least green or above, and sometimes you may need to insert 2 cannulas. And you may start IV fluids, sometimes iron drops, and you have to connect this patient to multi-monitor and monitor regularly heart rate, blood pressure, heart rhythm, oxygen saturation. Those are very important. Not only that, you may have to start fluid balance chart and monitor blood glucose level. And you have to, if patient is unconscious, you may have to provide the care for the unconscious patient. See how much you have to do for these poison patients. And we have to attend for his bowel, eye, oral, skin, bladder, those aspects we have to care. Sometimes this patient may be in pain. If it is so, the pain management also very important. Sometimes these poison patients, you know by experience, they are very aggressive, agitated. In that situation, you may use sedation. And most importantly, sometimes patient may not be that ill and they are emotionally very disturbed. It's our duty to care the patients and the emotional reassurance we have to do. Sometimes there may be family members, friends, emotionally they are not stable. We have to reassure them also. To do this, you have to know about the patients, their expectations, as well as why this was happened. Know your patient, and human compassionate care is very important. Think yourself whether you are doing that kind of service or not. It's high time for us to change ourselves. Then we do some investigations to exclude or confirm the diagnosis, and sometimes to decide whether the patient needs antidotes or detect complications. Very basic important investigation in a patient with poisoning. We have to check the sugar level, as well as ABG is very important. ECG and serum electrolytes, those are very important, with some other investigations. What is specimen to be collected? Usually, per sample of the blood, it's better to keep for the toxicological analysis, and rest we can send for the other investigation. As well as dermal contaminants, there may be gastric vomitus or aspirate fluid, oral fluid, urine. It's better to keep for the toxicological analysis. Sometimes if it is a homicidal act, it may be helpful. Then we have to think about the decontamination. What is decontamination? The poison is in contact with the poison person, but it is not absorbed into our system. Then if it is inhalation, usually we don't get the inhalation. By the time of inhalation, we have to remove the patients from source. But when patient come to the hospital, we have to look at the airway. There may be swelling in the airway. Patient may be in impending airway blockage. Then we have to secure the airway. And if it is ocular contamination, what do? You have to irrigate eye with the saline at least for 15 to 20 minutes. It's not 5 minutes, it's not 10 minutes, 15 to 20 minutes. Usually we do it from the medial to the lateral side, otherwise it can go into the other eye also, then other eye can be affected. If it is dermal contamination, you have to wash with soap and water 3 to 5 minutes. If there is any powder, first wipe out with the dry clothes or something available, then pour the water, otherwise absorption will be more. If it is gastrointestinal decontamination, there are 4 methods that we can practice: emesis, gastric lavage, activated charcoal, and whole bowel irrigation. But remember, earlier our practice was emesis. Every hospital, every medical ward has some corner for the induction of vomiting, emesis. Thinking that we were doing a good job, we killed a lot of patients. The patient who couldn't have died otherwise, they died due to aspiration pneumonia, no longer recommended this emesis in our country or any other countries in the world. Don't practice emesis. Even a few days ago, I got a call. One of the doctor's daughter has taken some paracetamol, and they go call me. So we asked patient we induce vomiting, but any tablet didn't come out. 2 days ago, to a consultant's daughter, right? Then I said, now it's not recommended. Still they are practicing, right? Don't do induce vomiting. It's very important. Then other thing, gastric lavage. We start gastric lavage when only patient is stabilized. If GCS is low, less than 10, we have to intubate the patient, then perform the gastric lavage. Usually the effect we can see as soon as we do, it will be effective. After 1 to 2 hours, it may not be effective. But in some instances, like sustained release tablets, enteric coated, and if patient has taken large amount of poison, in those circumstances, it may be used. There are contraindications for the gastric lavage. If patient has taken corrosives, then we don't do gastric lavage. And if there is a high risk of aspiration pneumonia like hydrocarbon intake, on those circumstances, don't perform gastric lavage. How we are going to do the gastric lavage? First, take the consent from the patient. Sometimes it may be difficult or relatives. Then what you do, you insert the NG tube 16 or 18 gauge. Sometimes Ryle's tube also. Then you can aspirate and make sure it's in the place. How do you make sure? You aspirate gastric content. If it is coming, you know it is in the stomach. If it is not, you can take 50 cc syringe, inject the air. While auscultating, you can hear the sound. Then what do you do? It's better to put mouth gag to prevent the biting. You take first sample for the medical legal aspect as a sample to send for the investigation. And after that, you aspirate as much as possible. When it is not coming, you may use normal saline or water as a lavage fluid. At a time, usually you use only 200 ml, not more than that. Then take it out, again put it, take it out. You can go up to 3 liters or till this return is clear. This procedure should be supervised by a doctor. Otherwise, it can lead to some other complications. The other method for the gastrointestinal decontamination is activated charcoal. We have to give as early as possible. It may be effective 1 to 2 hours. We use most of the time pesticide and the drugs poisoning. But there are no point of giving activated charcoal in some instances. You can easily remember, for acid and alkali, no point of giving activated charcoal. For alcohol and alcohol-related products, no point of giving activated charcoal. And this hydrocarbon, no point of giving activated charcoal. For the heavy metals also. You can easily remember. How do you give? Usually the dose is 1 gram per kilogram body weight. Adults usually give 50 gram. And the children maybe 25 gram. If it is less than 1 all-year children, we don't use activated charcoal. Then there are contraindications for activated charcoal also. If patient is having intestinal obstruction, don't give activated charcoal. And other thing, if patient has ingested corrosives, sometimes we may have to do the endoscopy. Then the procedure will be very difficult. We don't use activated charcoal. Other method, the god has given 2 holes. We tried with mouth to take the poison out. If it is not possible, other method will be whole bowel irrigation. For that, we use polyethylene glycol, especially for the toxins not absorbed by the charcoal like iron, lithium, buttons, batteries we use, and sometimes for the enteric coated drugs, sustained release drugs we may use. In addition to that, you know the drug traffickers, they use this body stuffing, or for that situation we may use polyethylene glycol. Then the other method, already there may be some poisons absorbed into body. Then we have to take it out. The natural method is through our urinary system, we enhance the process by urine alkalization. In addition to that, we may use some artificial method like peritoneal dialysis, hemodialysis, hemofiltration, and multiple dose of activated charcoal. Our target is to, usually we give sodium bicarbonate bolus dose followed by the infusion to achieve urine pH more than 7.5, preferably between 8 and 8.5. Or sometimes we may use multiple doses of activated charcoal to enhance elimination process, especially digoxin poison, theophylline, the Niagara poisoning, sometimes this mushroom poisoning. We use 50 gram every 4 hourly, maybe up to 24 to 48 hours. And other important aspects, the antidotes, there may be some poisons in the body, we can't take it out by this elimination process. Then we have to give some counteracting drugs, antidotes. You have to give the right antidotes, right dose at right time. You know, in OP we give atropine, paracetamol, anesthesia in neck, and there are a lot of antidotes that we can use. Then we have to think about the sending this patient home. It's very important. Or sending to disposition about the patients. Depending on the patient's condition, as well as the available facilities, we have to decide. Sometimes we may send patient to the home, or to other ward, or H2U, or sometimes ICU, to other hospital. Right? Yeah. Dr. Atula Kulasinghe, next speaker, he gave me 5 minutes. I think I have another 1 or 2 minutes, sorry. And it's your duty to make sure the transfer is safe. It's better to have a checklist when you are transferring patients and communicate with the receiving end. And always accompany the necessary equipments, drugs, and skilled staff. Now, other important thing, sometimes we may have to address the medical, legal, and ethical things. We have to refer some patients to police and JMO, not always. If patient remain unconscious, if we have any doubt about the circumstances, if it is a homicidal act, even if it is a suicidal act, if patient died, you have to inform the police and JMO. You have to refer most of the people to the psychiatrist or the psychologist, unless it is an accidental poisoning. And you have to bring down the family and do the education if it is accidental poison for a child, and you may refer to the MOH if it is a food poisoning. If it is related to the occupation, you may inform the Department of Labor. These are the take-home message I want to give. The time is life. You have to act quickly. The systematic approach is research RSI dead pathway. Induction of vomiting is not recommended. Gastric lavage is not similar to the vomiting. Some people think gastric lavage is vomiting. No, it's not. And prevention of further poisoning is our responsibility. Provide compassionate human care. Thank you very much.